So C is a second stage of labor. Its beginning is identified by if the patient feels the desire to defecate, the contractions become more prolonged and painful. If there is reflex desire to bear down during the contractions, the expulsive effort is accompanied by sustained expiratory grunt. Fourth is active management of labor. Here there's rupture of membranes, although this is not specific as it may occur earlier, even before start of labor. Pre-labor rupture of membranes or later, even to the degree that the fetus is delivered in an intact sac. Fifth is full dilatation of the cervix, that's 10 cm dilatation in between uterine contractions is the onset sure sign. So second is delivery room. The patient is transferred on a wheel or trolley to the delivery room. Put her in the lithotomy position, that's with her face up and her legs widely open. The lower abdomen, upper parts of the thighs, vulva and perineum are swabbed with antiseptic lotion. Use sterile leggings and towels are applied if indicated. Third is bearing down. Ask the patient to bear down during contraction and relax in between. Fourth is delivery of the head. The main aim during delivery of the head is to prevent perineal lacerations through the following instructions. First, support of the perineum. When the labia starts to separate by the head, a sterile pad is placed over the perineum and press on it with the right hand during uterine contraction. This is continued until crowning occurs to maintain flexion of the head. Crowning is the permanent distension of the vulvar ring by the fetal head, like a crown on the head. The head does not recede back in between uterine contraction. So once the head has opened up the vulvar ring like a crown, the head does not go back into the vagina between uterine contractions. So second is episiotomy. It is done at crowning when the perineum is stretched to the degree that it is about to tear. Third is swab and aspirate. The mouth and nose once the head is delivered before respiration is initiated and the liquor, meconium or blood is inhaled. Fourth is coils of the umbilical cord. If present around the neck, are slipped over the head, but if tight or multiple, they are caught between two clamps. So fifth is delivery of the shoulders. Gentle downward traction is applied to the head. The anterior shoulder slips under the symphysis pubis. The head is lifted upwards to deliver the posterior shoulder first, then downwards to deliver the anterior shoulder. 6 is delivery of the remainder of the body. Usually slips without difficulty. Otherwise, gentle traction is applied to complete delivery. 7th is clamping the cord. The baby is held by its ankles with the head downwards at a lower level than its mother for few seconds. This is indicated in preterm babies, erythroblastosis fetalis, suspicion of intracranial hemorrhage. This may be enhanced by milking the cord towards the baby to add about 100 ml of blood to its circulation. The cord is divided between two clamps to avoid bleeding from a possible second uniovular twin.